Hello and welcome to the first in this inaugural panel series on the topic of terminology in childhood speech sound disorder from the Child Speech Committee of the International Association of Communication Sciences and Disorders, which some of you may also know as IALP. My name's Yvonne Wren. I'm Associate Professor of Speech and Communication at the University of Bristol and also Director of Bristol Speech and Language Therapy Research Unit at North Bristol NHS Trust in the UK. And I'm also Chair of the International Association of Communication Sciences and Disorders Child Speech Committee. So first of all, I just want to tell you a little bit about IALP. It's the non-state actor in official relations with the World Health Organization and represents speech and language therapists or speech language pathologists and audiologists and phoniatricians. And working together across the globe, we help to ensure that our professions and those we serve are recognized and have influence. And you can see on the slide there that we have a vision to facilitate better understanding for people with communication and swallowing disorders, and that the mission of IALP, or the International Association, is to improve the quality of life for those with communication, speech, language, voice, hearing, and swallowing needs. So just to tell you a little bit about this panel series, terminology in the field of speech language pathology is an ongoing struggle. We use many terms, but often the same term may mean different things to different people. And yet there are other populations of people with communication impairment where no label yet exists. The Child Speech Committee for the International Association has a particular interest, unsurprisingly, in childhood speech disorder. The term speech sound disorder, or SSD, is now commonly used to describe many children with childhood speech disorder, but SSD itself covers a range of conditions and presentations, and it also overlaps with other labels. So in this series, we're going to explore the term SSD and how it relates to other conditions, and how that affects how we might describe and define children's presentations and needs. The panel series will cover 4 broad areas as shown on this slide. Today, we're pleased to welcome the IALP Child Language Committee to join us in talking about SSD and DLD and asking where they overlap and where they separate. In the second panel with the IALP Motor Speech Disorders Committee, we'll be considering SSD as a general term and also CAS, or childhood apraxia of speech, to explore how motor planning disorders should be classified in children. And this will be followed by a panel with the IALP Cleft Palate and Craniofacial Committee on SSD and cleft palate, exploring how anatomy and physiology affect the way we label and describe children with SSD. And finally, with other members of the Child Speech Committee, we will consider the distinction between SSD and speech difference, with a particular focus on diverse communities. But before we get started, we would like to remember a legend in the field of speech and language therapy. Following the very sad news earlier this month, we will just take a moment to acknowledge Professor James Law's contribution to the field of developmental speech and language disorders. James was a world-leading researcher and tireless in his efforts to bring evidence-based practices to services for children with language difficulties. He gave his time, knowledge, and energy to countless speech and language therapists and researchers with the aim of increasing the capacity of the profession worldwide to conduct high-quality research which could improve the lives of children and young people with language and communication needs. James understood that research can only bring benefits if it's recognized in policy and used in practice. Through building partnerships across disciplines and sectors, he brought real-world benefits to thousands of children with speech, language, and communication needs. As leader of the Cost Action European Research Network, enhancing children's oral language skills across Europe, and as a member of the Catalyse team, bringing consensus to the terminology used for DLD, James's work directly influences the content of today's discussion. And as we reflect on James's contribution, it gives me great pleasure to welcome our panel speakers today, beginning with one of his colleagues at Newcastle. Dr Helen Stringer is a speech and language therapist and lecturer in speech and language sciences at Newcastle University in the UK, and is a fellow of the Royal College of Speech and Language Therapists. She provides support and mentoring for speech and language therapists researching their practice in the northeast of England. Helen was also a member of the Catalysed Consortia that developed the consensus terminology for DLD, and she's also a member of the Child Speech Sound Disorder Research Network. Her research includes phonological awareness in the context of speech sound disorder, behaviour change theory and techniques across speech and language therapy, and its interface with health and education services. Helen will examine the links between the terminology and the etiology of speech sound disorder in the context of the Catalysed 2 Consortium DLD recommendations to address the topic of DLD, phonology or speech sound disorder. Why does it matter? Helen will hand on to Dr. Marit Clarusen, who's a speech and language therapist and assistant professor at the Department of Language and Communication at the University of Southern Denmark. She's a fellow of the Danish Audiologopedic Association and a member of the International Expert Panel on Multilingual Children's Speech. Marit's research focuses on the phonological development and speech sound disorders in Danish-speaking children, as well as evidence-based practice for children with speech and language needs in Denmark. Marit will speak on the topic of what's in a name, SSD and DLD from a Danish perspective. Specifically, she will present how Denmark, a non-English speaking country, has adapted and translated the two labels for use in Danish SLT practice and what challenges we are faced with in Denmark. And Marit will hand over to Kakia Petinou, who is a professor and chair of the Department of Rehabilitation Sciences at the School of Health Sciences in the Cyprus University of Technology program in Speech and Language Pathology. She's a member of the International Association of Communication Sciences and Disorders, and from 2020, she has been chair of the Autism Committee of IALP. Her research interests focus on the linguistic development of children with late onset of expressive language and its relationship to persistent language challenges and interface with developmental language disorder, childhood apraxia of speech sound disorders, autism spectrum disorders, and narrative skills across pathologies. She's a keen supporter of evidence-based practice and theory-motivated intervention. So, moving on, we are very keen for you to join in the discussion. Now, whilst it would have been lovely to have you all on Zoom, we had over 550 people register for today's event, and so we are running it via YouTube, but nevertheless, there is the possibility to contribute. So what we would like you to do is ideally to use Twitter and to use the hashtag SSDDLD, and also to tag IALP Global. Please also do like comments from others, because we'll try and pick up those which are getting the most interest in the discussion afterwards. And I'm just going to say a quick thank you to Dr. Joanne Cleland from the University of Strathclyde, who's monitoring the Twitter feed and will provide comments for me to suggest to the panel at the end of the presentations. If you don't use Twitter, there is also the option to email. So you can see Annette Foxboyer's email address there, and please use SSDDLD in your subject line so that Annette can pick up these emails as we go. And we know that this is being recorded, and so welcome to those of you who are watching after the live event. Please still do engage with the discussion on Twitter, and also take the opportunity to discuss the content with colleagues. We are also planning an event for those in the Asia Pacific region. We do appreciate that it is near midnight for many of you on a Friday, so we may well be doing something quite different to listening to us just now, but we will circulate information about a post recording event for discussion in the Asia Pacific region. Okay, I'm now going to hand over to Helen to get us started. Helen will hand straight on to Marit and then to Kakia, and then I will be back with you a bit later. Thank you very much, Helen.
Thank you. So I'm just going to share my screen with you. Okay, as Yvonne said, I'm going to talk to you about DLD, phonology or speech sound disorder, and does it matter what we use, what terminology we use. First of all, I would like to acknowledge the contribution of my colleagues, past and present, who are the Child Speech Sound Disorder Research Network, who are listed here, a really wonderful list of doctors, and also my colleague, Professor Christina McKean here at Newcastle, and also on the Catalyse Consortium. So I'm going to talk about aspects of developmental language disorder as proposed by Bishop and colleagues with the Catalyse Consortium in 2017, and how that leads us to the proposal for an agreed terminology for speech sound disorder. I'm talking very much in an English language context, and Marit and Kakia will be talking from Danish and Cypriot Greek perspectives. So first of all, some background to Catalyse and the language terminology. At this point, I think it's important that we note that the previous predominant term of specific language impairment, or SLI, is now a subset of DLD. If we look at this Venn diagram from the Catalyse paper, yellow is everything that sits within speech, language and communication needs, or SLCN. And this is a term widely used in the UK for over a decade now. And this is broken down into language disorder, speech sound disorder, and within language disorder to DLD. So where does phonology fit in? The overlap of DLD and SSD is just labelled phonology. Both expressive and phonological processing fit in here. This could lead us to a diagnostic label of DLD phonology. But if we are looking for speech sound disorder, we must go wider than DLD phonology. Phonological disorders frequently co-occur with other types of speech sound disorder. So does DLD phonology give us enough information about the speech sound disorder? Indeed, does it tell us enough about phonological disorders? We must also remember that there are years of a child's life before it would be appropriate to give a label of DLD. For the preschool children with language delay and disorder that are not DLD, as we don't know if they will persist at this point, it is important to have the means to make a joint diagnosis pre-DLD, when the possibility of DLD is being monitored. It's important to consider intervention that spans speech and language, as in some cases it can be difficult to separate out whether language or speech is the most important or prominent condition that we're looking at. In the 2017 Catalyse paper, there are 12 consensus statements that provide support for the concept of DLD. And I've chosen to consider these three in relation to speech sound disorder. So looking at statement 1, if it is important to have consistent terminology in language problems, that includes speech. So we're on the same page as Catalyse here. Waring and Knight, in their important 2013 paper, proposed that a classification system for speech sound disorder needs to classify all children with speech sound disorder of unknown origin into discrete subgroups, have accurate specific and sensitive diagnostic markers, have universal applicability, improve clinical management by directing treatment differentiation, be feasibly implemented in the clinical setting, and contribute towards an explanation of childhood speech sound disorder. When considering terminology to be used in a clinical setting, I think you'll all agree that directing us to intervention is a crucial component of this. So if we move on to statements 2 and 3, here we're considering a persisting difficulty with a significant impact on everyday social interactions or educational progress. Language continues to develop throughout our lives. As speech and language pathologists, you've probably spotted that. We may encounter new syntactic forms, and we will certainly encounter new vocabulary and new communication contexts throughout our lives. However, speech sounds are finite. We have a set number of phones in a language which act in a rule-based way to signal meaning. In English, typically developing children have acquired speech sounds by around 6 to 7 years of age and are using them in the same way that adults do. We don't acquire new sounds as we get older or have a different set of phonological rules for people over 60. Preschool speech sound disorder can impact everyday social interactions and educational progress with long-lasting impact, even if the speech sound disorder itself is resolved, which of course it is not always. There is a similar picture in speech sound disorder to DLD, in as much as it can be difficult to predict a poor prognosis. But as we see with disorders such as childhood apraxia of speech, where there is difficulty in a range of areas, prognosis is likely to be poor. And as Yvonne said, there will be future panel discussions which will cover these areas. So we're now going to consider how speech sound disorder maps onto the DLD flowchart. If prognosis is good, speech sound disorder, not DLD with phonology, is the correct terminology. So the child separates from DLD here. If the prognosis is poor, we continue along the flowchart. If the child has language disorder and speech sound disorder associated with a biomedical condition, we would really diagnose DLD on its own, or would we add information about speech sound disorder? And this is what we really want to discuss today. Under any circumstances, should we really use DLD with phonology if the child has a speech sound disorder? I don't think so. If co-occurring, I think it's much better to have DLD and SLD. This would help us avoid a speech and language hierarchy or any overshadowing by one condition or the other. They can co-occur and be equally important for the child. So this brief overview of terminology is from the literature over the decades. I'll not go into it in detail here, as Waring and Knight and others have done this really well in the past. We are broadly looking at linguistic and psycholinguistic terms and terms that consider the etiology of speech sound disorder. When considering clinical practice and research, we need to consider if we should use the same terminology in both contexts or not. From the Catalyse 2017 paper, I've selected some sections that I think are important in relation to how we consider speech sound disorder terminology. It is not DLD if the prognosis is good, as it is for many children with speech sound disorder, as we do have a number of efficacious evidence-based interventions which we can implement as clinicians. Problems with speech production do not fall within DLD, yet many children do have problems with speech production, either persisting or transient. And the debate has certainly moved forward since 2013 or 2017. And with evidence-based and well-researched diagnostic tools, we can make much more accurate diagnoses about the categories of speech production that children are having difficulties with. We now move on to considering the age of diagnosis, or when children present to specialist services. It is important for all children that we assess both speech and language, because children with unintelligible speech may well have language disorders that are not very evident at that point. It's not just the case for children over 5 years old, but it's very important as well for children younger than that. So we propose that for all children who have any type of speech sound disorder, even if DLD co-occurs, that a dual diagnosis of DLD and SSD would be appropriate for a child who also shows signs of language disorder or delay. So phonological awareness is also mentioned in Catalyse, and although not itself a speech sound disorder, it is an element of phonology. Phonological awareness has a role in speech, vocabulary and literacy, so careful assessment is required to make sure of the appropriate diagnosis. So considering the volume of research relating to literacy and phonological awareness, any proposed interactive relationship between speech development and phonological awareness is actually not recognised in the Catalyse paper. Their focus is very much on the relationship with literacy. We would not diagnose DLD on the basis of poor phonological awareness alone, and nor would we diagnose speech sound disorder for a child who didn't have a production difficulty but did have phonological awareness difficulties. In that case, we would be diagnosing phonological awareness difficulties. So this takes us to a proposed hierarchy of terminology for children with speech sound disorder based on Dodd's model. So this has been developed by the Child Speech Sound Disorder Research Network, and we've tested it out with groups of speech and language therapists in the UK. So first of all, we suggest that speech sound disorder is the overarching term for all types of atypical speech sound development. This is in line with Catalyse, and also using disorder in the terminology, and as well it follows an international trend where speech sound disorder is being adopted. And this term was acceptable to all of our groups of speech and language therapists that we talk to about this. It's also a useful term when talking to parents, especially in the early stages of diagnosis, when we may still be exploring error patterns and response to intervention. However, as clinicians, we need more depth. We need terminology that supports our choice of intervention. So at the second level, we consider if we know the cause of the speech sound disorder or not, and we differentiate between speech sound disorders associated with a medical condition or an underlying deficit, in contrast with the larger number of children for whom we cannot yet define a cause. So we have speech sound disorder associated with something, or speech sound disorder of unknown origin. And level 3 takes us to the more refined label that can support our choice of intervention. Some of these labels can co-occur with each other. For example, articulation disorders can co-occur with different types of phonological difficulty. For a child with phonological difficulties and some motor difficulties, these labels may also be transitory as they respond to our expertly chosen intervention. And some of those associated with medical or underlying conditions are likely to be a lifelong diagnosis. We propose motor difficulties are differentiated into articulation disorders, which could be structural or non-structural, childhood apraxia of speech and dysarthria. And then that speech sound disorder that has a linguistic origin affecting phonology, that these are classified into phonological delay, consistent phonological disorder, and inconsistent phonological disorder, in line with Dodd and subsequent researchers. So phonological awareness difficulties, here implicit and explicit, are often, but not always, associated with speech sound disorder. So here we have a clear overlap with the DLD terminology, but from Catalyse, we have a clear steer not to label a child with literacy difficulties and poor phonological awareness as DLD. And similarly, we would not label a child with speech sound disorder who didn't actually have a productive speech sound disorder. If we go back to Waring and Knight in 2013, the proposed terminology here does meet these criteria. We tick all the boxes. So in conclusion, there is an overlap between speech sound disorder and DLD, but for young children, where DLD is not yet an appropriate diagnosis, we need to be mindful of the relationship between speech sound disorder and delay or disorder in different modalities of language. DLD with phonology as a term for speech sound disorder implies a hierarchy which does not exist. DLD with phonology does not indicate the type of disorder the child presents with, and DLD with phonology does not signpost an appropriate intervention. The common taxonomy at the detail proposed here supports practice in terms of giving us a common terminology with which to discuss children with colleagues and signpost us to evidence-based interventions. And in research, it gives us a categorization of participants and a direct route into implementation by practitioners. So thank you very much for listening. And I will now hand over to Dr. Marit Clarusen.
Yes, thank you, Helen, for your presentation. I'm now going to continue with what's in a name, SSD and DLD, from a Danish perspective. Because, as you heard, I'm a speech and language therapist working in Denmark. Denmark has a population of around 5.8 million people, and our majority language is Danish. So we are one of many non-English speaking countries who follow research published in English. And this includes research about terminology and classification of children and children's speech and language disorders. So also in Denmark, we have read the catalyzed papers and also the review about how children with speech sound disorders should be classified by Vaering and Knight that Helen just presented. So in Denmark, we are faced with the challenge of implementing English terms suggested in English research or published in English and implement them into Danish speech and language therapy practice. And also another challenge is that Danish speech and language therapy practice is based on a pedagogical tradition instead of a medical one. So this has implications for which terminology we are using in Denmark. So what I'm going to cover in my presentation is what's in a name in Denmark. And here I want to present what's in the label speech sound disorder in Denmark and developmental language disorder, DLD, as well as the interface between phonological impairments and DLD. And in the second part, I want to cover does the name matter for Danish SLT practice. So I'm going to start with the name SSD, and the English term SSD has been adapted to Danish into the Danish term udtalevanskeligheder, and the speech part is kept in the Danish term, but the disorder part has been adapted to impairment, and this is most likely due to our pedagogical tradition, which makes that we are a little bit more hesitant with using the term disorder. The term udtalevanskeligheder is used as the overarching term, the umbrella term in Denmark for children with speech disorders like SSD in English-speaking countries. And children are then divided into SSD due to organic origin or unknown origin. And the terminology for children with SSD due to unknown origin has changed the last 5 years due to international publications on classification of SSD, published norms for the phonological development of Danish-speaking children, published new assessment material, as well as data on Danish-speaking children with SSD about characteristics and classification. So if we travel back in time around 5 years ago, all children would have gotten the label dysphonology or phonological impairment without further classification. And this is most likely due to the lack of norms. We didn't know which phonological patterns were typical at which age and which were atypical. But now we do have norms, and now children are divided into subgroups according to Dodds classification model, where each subgroup has been adapted to a Danish term. So we have artikulationsvanskeligheder, which is the English articulation disorder. fonologisk forsinkelse, phonological delay, consistent fonologisk vanskelighed, which is the consistent phonological disorder, inconsistent fonologisk vanskelighed, which is the inconsistent phonological disorder, and finally verbal dyspraxie, which is childhood apraxia of speech. And here it should be noted that actually, even though it says disorders in a DOTS classification model, every disorder term has been adapted to impairment in Danish, and most likely again because we try to avoid a disorder because it sounds more severe, and due to the pedagogical tradition, we try to avoid this term. And often impairment is received as less severe. So let's move on to the term DLD in Denmark. Before Catalyse and the Catalyse papers and the Catalyse consortium, we were in the same situation as in the English-speaking countries. So a lot of different labels were used for the children with language disorders. So for example, specific language disorder or primary language impairment, or even just language impairment or language disorder were used for these children. After the Catalyse paper and Catalyse consortium, also Denmark has changed the name. However, we did not have a Delphi consensus study that was carried out in Denmark, but we had researchers facilitating the implementation of a new diagnosis based on the English Catalyse papers. And the DLD term and then actually was translated directly into a Danish term, which now is udviklingsmæssige sprogforstyrrelser. Or actually, we also use the English abbreviation DLD. And here for this name, we kept the disorder in forstyrrelse to point out the severeness of this language disorder and the poor prognosis. So we had the use of different names, and which names are being used now. We have a recent survey of Danish SLT's practices and knowledge about this area. With around 200 SLTs who participated in the study. And the survey showed that 84% of the participating SLTs use the term DLD now. Only 9% use still the old term SLI, and 7% use both SLI and DLD. But the survey also showed that many SLTs still are confused about the terminology due to shifts in terminology. And what about the identification of SSD and DLD in Denmark? Here we can see some differences. Children with SSD comprise one of the biggest client group in Denmark in Danish SLT practice, as also reported for other countries. And Danish SLTs are very knowledgeable and experienced in the identification of SSD, as well as subgrouping of speech sound disorders in children. And we know that from a recent study where we investigated this. However, if we look at the identification and working with DLD, many SLTs report that they don't feel that they have enough knowledge and experience with the identification of children with DLD. So only 36% of the participating SLTs in the survey study said that they had enough knowledge about DLD, and only 7% reported that they had experience with working with children with DLD. And what about then about the interface between SSD and DLD? Because as Helen also just presented, the Catalyse paper actually points out that children with DLD also can have phonological problems. So 3 of the 5 SSD subgroups can actually be part of the DLD diagnosis. But a Danish SLT is then aware of that there is this interface between SSD and DLD. We also asked about that and what kind of language problems they think of when they are assessing children with DLD. And here they reported that they mostly think about impaired grammar, impaired language reception, and impaired vocabulary with DLD. Only 70%, so 30%, were not aware of that phonological impairment actually also can be part of DLD. And this is reflected then in the assessment process, as only 39% assess phonology when assessing children with suspected DLD. And this is most likely due to that a lot of research actually has focused on the morphological and syntactic problems that children with DLD can have. In Denmark, we don't have a lot of research about DLD in Danish-speaking children, but the studies that we have indicate that also children with DLD in Denmark often have difficulties with morphology, syntax, semantics, word finding, but also speech sounds. So often we can see in Danish-speaking children with DLD that they still have speech errors when they enter school. And normally, typically developing children are actually already finished with their phonological development around 3.5 years. So this is really a big difference. So this study about SLD practice and knowledge in Danish SLD practice about SSD and DLD shows that there is a lack of knowledge about where SSD and DLD can overlap. And this could actually lead to the wrong diagnosis, maybe also the wrong intervention approach, and also maybe the wrong prognosis for a child. And I've mentioned the word diagnosis several times. And actually making a diagnosis in Denmark is a little bit special because Danish SLT is actually not allowed to diagnose children. Only medics like ear, nose, throat doctors or neuropediatricians or psychiatrists are actually allowed to diagnose children. But even though Danish SLTs are not allowed to diagnose children, they typically assess children with suspected speech and or language disorders and decide if children are eligible for intervention as well as which kind of intervention. But in general, we have no national guidelines for assessment. And the same is true for intervention. We have no national guidelines for intervention. And this means that services vary broadly from municipality to municipality. So some SLTs report that they are allowed only to offer direct intervention to children with SSD, but not DLD. And some SLTs, on the contrary, report that it has been decided to give less intervention to children with SSD in order to have resources for children with DLD. So now the name matters a lot because it actually decides whether you get intervention and how much intervention you will receive. Besides the factor with the variation from municipality to municipality, we also see a variation in the service that the children are offered depending on the SLT. And here the factor knowledge about DLD, SSD, as well as phonological problems as part of DLD is of importance, and also how hesitant the SLT might be regarding giving a more severe or actually official diagnosis, which DLD now is. And here we can see in the survey study that some SLTs in Denmark are not comfortable with actually giving this official diagnosis when we are not allowed to diagnose children. And this then leads to that some SLTs only label the child as having a language disorder or language impairment instead of describing it or labeling it, naming it as DLD, even though they know maybe it's DLD. So there we have maybe again the roots in the pedagogical tradition, which also influence here how we deal with DLD in practice. So what are important future steps for Denmark? Right now we can see that the term is still quite new, DLD in Denmark, and we need to offer continuing professional development both to ESLTs, but also to key collaborators to ensure early and correct identification of children with SSD as well as DLD. We need to raise awareness about DLD and the interface between DLD and SSD, because right now it looks like a lot of Danish SLTs mostly think about syntactic and morphological problems when thinking about DLD. And maybe we should work on establishing national guidelines or coordination between municipalities to ensure that all Danish children with DLD and SSD receive the most adequate treatment independently of which municipality the child is part of. And guidelines could then be with regard to which children get referred to as SLTs and what kind of assessments are carried out by whom and when. So for example, we could follow the Catalyze papers with the recommendation that broader language skills should be assessed in a child if the phonological problems continue beyond 5 years of age. and that it should be avoided to rely only on a grammatical assistant for children with suspected DLD, because SSD can co-occur. And finally, maybe we should have some guidelines for what intervention is offered. Should it be group intervention, individual therapy, direct therapy? And we have a lot of discussion going on right now regarding early intervention and being able to offering continuing support after school entry, because we know that children with DLD often need support after they have entered school. So thank you for your attention. This was a little bit about the situation in Denmark regarding SSD and DLD. And now I want to hand over to Professor Kakia Petinou. And thank you for now.
Thank you very much for this wonderful presentation so far. My name is Kakia Petinou. I'm from the Department of Rehabilitation Sciences at the Cyprus University of Technology, which is situated in Limassol. It's a really nice modern coastal area, and I hope sometime you can visit us with a lot of research. I work at the university, and I'm also director of the Thera Lab, that is the Speech and Language Rehabilitation Laboratory, situated and housed at our university clinic. What is in a name? What does it matter? What's the interface between SSD and DLD? Where do they separate and where do they overlap? I think this is the $1 million question. We do tend to study SSD and DLD from different perspectives, but when it comes to studying them together, that poses challenges because of the way of the diversity, of the linguistic diversity, of all this terminology, of all this new research that is coming up all the time, and underscores the need to develop taxonomy and to also change our perspective. Communication and language are dynamic systems and processes with all language subsystems in interaction and synergy as a function of specific developmental stages. That is, one system can support the other during the typical course of language development. For example, phonology can support the lexicon, and then the lexicon can support the syntax, and vice versa, depending on the child's developmental age. I follow the three-pillar philosophy, evidence-based practice, theory-motivated therapy, and data-driven findings that can be translated into clinical practice and can inform evidence-based practice. I'm also a keen supporter of cross-language validation, implementation of efficacy for best service provision, and I do think this is our vision and mission as speech and language therapists, both as researchers. I work under the auspices of an overarching umbrella project. We call it Logos Project. It's Linguistic Outcomes Growth of Speech. It's a Greek word which means speech. So it took us some time to really come up with an acronym. But under this project, we run a lot of studies on SSD, DLD, and so on. Speech sound disorders is one of the most prevalent communication impairment challenges, about with 8 to 9% of children affected. 3.7% of children present with DLD, and 15% of children present with DLD and SSD, according to work that comes out from the United States, Larry Schreiberg's and Bruce Tomlinson's work. Of course, I know some of these issues will come up later, but and some of the numbers will change. So also we see a lot of children with ASD having SSD comorbidity that shoots up to 20%. And there is converging evidence across numerous global cohort studies supporting the evidence of SSD and DLD outcomes, according to Rescorlas and Dale's latest book on late talking children. The impact, speech intelligibility is the backbone of the language subsystems, given that it starts from early on. Lexical representations, lexical access, morphophonological and morphosyntax, phonological awareness skills that Helen mentioned, pre-literacy and literacy skills depend on a robust phonological system that is compromised by SSD and of course DLD. Now, this is a continuum I would like to see that if you start with atypical error patterns in the form of SSD or even as a poor vocabulary at the age of 2, because this is one of the first manifestations of later linguistic challenges, comes up through your vocabulary, expressive vocabulary, and your phonological or phonetic systems. It leads to poor phonological awareness, to additional language impairment, to the family risk of dyslexia, developmental language delay, and so on and so on. Basically, bottom line that if you start with poor phonology at the beginning, you might end up with persistent language problems in the form of DLD or increased risk for reading and spelling difficulties. So again, early language delay at 2 and 3 with slow recovery leads to poor intelligibility, limited phonetic resources, restricted sentence structure, poor phonological awareness skills from age 3 and on, even 4. Then this would lead into persistent language delays in the form of DLD from the age of 6 even to 17 years and so on. So our key component is early intervention, early diagnosis, and early intervention. So questions, concerns, concepts and concerns. Why are we here today? What are we discussing? And I think it's the road less traveled, as I'm saying. So it's really nice to be part of this panel today, that there is interface between DLD and SSD. That is for sure. We all agree, and there is converging evidence on that. There are two distinct categories, though, when it comes to the diagnosis and treatment. Are we asking this question? In a sense, yes, because we are diagnosing two systems that might be the faces of the same coin. Let's see, are they part of a continuum? Are they same but sometimes different? What is the line of demarcation? Where do we know that it's SSD, DLD, and what comes first? And also, what is our common terminology in taxonomy of SSD? I think that's another issue we need to be concerned of. The importance of taxonomy map, does it help? How does it help us prioritize intervention goals? How do we capitalize on research findings? And our intervention, what does it help us attack first, given that we have all these subsystems? How do we achieve a wide system generalization? I adopt this from Judy Gaywood, who's doing a lot of work on phonological intervention and wide system approaches. When you target one area, then you see a lot of improvement in another area. You see this interlinguistic generalization. Well, Judith Gaywood talks about phonological, actually, generalization. How do you go from phonology to morphophonology? And I'm going to give you some examples that I derived from my work with Greek-speaking children and children who speak the Cypriot Greek dialect in Cyprus. Okay, let's say if you take a child who deletes final consonants, then a child might not use plurality and might not also use third person singular to mark the third person verb. Let's say in Greek, we can have the word bale, which is, again, a lack of a deletion of final consonant. And then if we target final S, we see this wide system generalization to plurality and also to other aspects of the verb system. So this is what I call a very basic example of interface that phonology can really affect all other systems. Now, intervention attacking, how do we attack different subsystems? This brings us to the when and what do we attack and diagnose. SSD is manifested or assessed at earlier chronological ages than DLD. Given that DLD is not diagnosed until later, then I think one of the first things we see in children who might be at risk for chronic persistent language delay is shown in their lexicon. It's also shown in their speech sound system. Sometimes, yes, as we say, because a restricted lexical and phonological profile is the first to appear in the case of LTs, the late talkers that comprise most of the bulk of pediatric diagnosis or pediatric caseloads. Okay, talking about taxonomy, I usually refer to Bowen's umbrella taxonomy, but I'm also very keen and supportive of taxonomical diagrams we saw on the basis of the catalyze and also of what we see in Denmark and in the UK. Taxonomy, it's very important. It's our therapy roadmap, it's our intervention GPS. This is what I call it. It gives you a hunch, a better idea of what to do and where to go when it comes to the diagnosis, the intervention, and also you can look for certain other challenges in the form of DLD, which lie in the underlying representation and in the way children process speech and language, which is also a robust prognostic factor. We'll come back to this later. Now, the challenge we have coming from all these diverse linguistic backgrounds, taxonomy, and also, as we said, systems that allow, that will have a universal applicability will really help us in terms of developing common systems of taxonomy, intervention, and diagnosis. I like this cartoon because it underscores the need for universal let's say, not characteristics, but guidelines. It's this examiner, this is usually asked for a first selection, everybody has to take the same exam. The same exam is to actually either be diagnosed or go through a certain intervention. Please climb that tree. You know that the tree is not for everybody. So I think we need to be concerned with that. Now, coming back to an interface, what is the interconnectedness among language subsystems as a dynamic process? Never forget that we're dealing with a dynamic process with different subsystems. And I refer to Carol Stoel-Gammon's 2011 article in the Journal of Child Language talking about this, which I find it very, very helpful in terms of guiding our knowledge. There is a robust interaction between lexical and phonological components during the process of language acquisition. During the first year of life, the phonological structures of which early words are made of empirically form the building blocks for subsequent lexical development and set the pace for the emergence of language and usually the lexicon. Okay, so initially the lexicon and the phonological aspect are very, very much connected at the beginning. At the early stages of language development. Gradually, according to the critical mass hypothesis, children and toddlers will develop words, and after that, these words will go through a restructuring of their underlying mechanism and representation. So this phonological organization shifts from a gestalt to a much more analytic form, which may impact on the phonological lexical interface in terms of phonological, let's say, bootstrapping. Now, do not be intimidated by all these boxes and arrows. I am going to summarize in a nutshell our data from examining language as a system, as a dynamic system. In this case, we take phonology, that is the phonetic inventory, and we see that your phonetic inventory at the beginning at 28 months, your PIS, phonetic inventory size, is a factor that correlates highly with MLU, and of course the lexical diversity, the number of different words you're producing. And then again, this is concurrently within the age of 28 months. And then we look at phonetic inventory size again, and we saw that it really highly correlated with itself predictively, that if you start with a robust phonological system, then you will end up again with a good phonological system that will support all your other linguistic parameters. Now, it's not an easy story. It's not as it's much more complicated than that, but if you're much more interested in learning about this, you can see our paper in the Journal of Psycholinguistic Research, and you can email me anytime to go through this. Now, when we saw this particular data behavior, we wanted to see what subgroups of children were really using this model. And we ran a cluster K-means analysis where this actually divides our children in poor, in high performance and low performance on the basis of their phonetic inventories. And we saw that low performance were children with 6 or 7 phonemes, and high performance were children with 13 phonemes, established segments. And surprisingly, we saw that children with high phonetic inventories were not really using the system. You know, they had outgrown they're using different subtypes of phonetic inventory to get into other subsystems. And eventually we saw that it was the children who were protracted in a way, not protracted, who were less skilled in their phonetic inventories that were actually harnessing, they were using their phonetic inventories to advance more words, okay, and go through the MLU. So what I'm saying is that even at 28 months, even children who might be at risk for DLD are using their phonetic inventories, and we can use, they're using their phonetic inventories to go from one linguistic system to the other. Maybe not in the best optimum way, but this has implications for us. We can use phonology to support lexicon, and also to support morphophonology later. It's not that we will stop the surfacing of DLD, but we might also give children more resources in terms of dealing with later persistent language delay or language disorder. So PIS, that is phonetic inventory, shows a strong relationship with words and grammar synchronically, and importantly, at 28 months, which is a very important age, shows a strong relationship with sounds, segments, words, and grammar predictably. It can actually predict what you're going to be, how is your system going to be later in life. So also by dividing our children, we saw that this system was more supported by children who were not less, who were a little more protracted in their use of phonological and segmental skills. Now, research findings translated into intervention goals. In a nutshell, there is plenty to be done on the basis of phonological skills. Do we target phonology? Do we target development of core vocabulary? Do we target all aspects of the system? When, what, and how do we prioritize? And I'm focusing on phonology because I think my idea was that this is what you see at the beginning before even children develop a developmental language disorder, because DLD is manifested. You see this in terms of a phonological delay in a way. The parameters to consider: intervention goals, stimulability in the form of child phonetic knowledge. A child with good stimulability has good prognosis. An age of acquisition of words that we're using. We can use words the child already knows that can contribute to a wide system change in a future DLD or SSD surfacing. And semantic and phonological knowledge is also very important. We can capitalize on child's knowledge at the beginning of therapy to really try to build a robust system in these children. A good, robust phonetic system will assist in developing and maintaining other linguistic skills such as the lexicon. Early assessment should focus also on relationships among linguistic parameters. We need to move away from measuring only the lexicon, and also cross-linguistic typology differences might give us different results. What is spared and what is lost in a child's linguistic output depends on the child, on the language, on the ambient language. And we can extend this model to children with late onset of expressive language. And also, when do we assess SSD manifest earlier than DLD characteristics. I hope we all agree on that. How do we assess? We use clinical observations and clinical tools. In Cyprus, we are actually trying to develop sensitive and specific tools for, and we're almost there in terms of using phonological data, developmental data in developing tools. Okay, and what do we assess? We assess phonetic, phonological, prosodic, intelligibility index, and stimulability, as I say. And why do we assess? By now you have the answer. We assess these children early so we can give them the head start, because children who are delayed in their phonetic inventories, in their phonological skills early on, and their lexicon is restricted because you can see this intimate relationship, then if these children don't make enough progress early on, these are the children whose prognosis might not be very good. This will be the children who might develop later DLD characteristics, phonological awareness challenges, and so on and so on. The take-home message, that phonology as the first, I would say, parameter to target the characteristics might precede DLD output. And I'm open to discussion about that and arguing. I base my data on what I see from the children I work with. Early assessment should focus on relationships among linguistic parameters. We should never leave behind all other linguistic parameters, the subsystems. And a good, robust phonetic system will assist in developing and maintaining other linguistic skills such as lexicon. It might not get the children out of the woods. I mean, if you're going to develop a DLD, which will surface later, you're not going to prevent it, but you're going to alleviate some of the problems. Now, I'm saying this rhetorically or exploratory. I don't have the answer to this, and again, I'm open to discussion. The SSD taxonomy will guide our intervention, which is very important, and the prognosis. Children, I think, and not I think, that I see from my clinical research, also and from my research as in the field of psycholinguistics, developmental psycholinguistics, I see that children who don't make much progress, children who don't really adopt the rules you're teaching them, especially in phonology, will also end up with a DLD diagnosis later along the lines. And also the speed of progress is also a good predictor, and the cross-linguistic typology that determines what we see in terms of the output. The characteristics are determined by the typology of a language, but the taxonomy should be something universal. And there is DLD and SSD interface and intimate relationship. Okay, thank you very much.
Thank you, Kakia. That's fantastic. And thank you also to Marit and Helen for three fascinating and very thought-provoking talks. Kakia, you made the point that speech and language are two sides of the same coin. And I think this is the fundamental issue, isn't it? That we're talking about two concepts that we think of in two quite distinct ways as speech language therapists, speech language pathologists, but they are fundamentally interrelated. And I enjoyed the way that you talked about how we can target speech as a way into addressing problems with language. Marit, I thought that your points about SSD in Denmark and in Danish actually had a lot of relevance for lots of other languages as well. And your point about the lack of knowledge about where SSD and DLD can overlap can lead to the wrong diagnosis and the wrong clinical management. So that's really important. You also made some really good points about that broader language problems should be assessed if the phonological problems continue beyond age 5. I want to pick up on that in a bit, given some of the questions that have come through, and also that important to avoid over-reliance on grammatical assessment for children with suspected DLD, because we might be missing some of those phonological or speech errors. And Helen, it was really helpful to have that overview of how SSD sits with the catalyzed model and the argument that actually a dual diagnosis actually is more informative than perhaps DLD with phonology or DLD with SSD. So I think we'll come back to that as well. We have had some questions through via Twitter and via email. So to all of those of you who are listening in, do please continue to add questions and comments and like those from others. But let's kick off. We've got we have 25 minutes. So let's just kick off with one. So this one is a question about the label DLD phonology. So, perhaps Helen, starting with you. So the question is, does it necessarily involve expressive phonological difficulties? Isn't it a label that fits for children who have attested phonological processing difficulties that contribute to their DLD? So, if the child also has problems in speech out, well, perhaps we go with that one first because that's a follow-up question. So how do we deal with this with children whose expressive phonological difficulties have resolved, but they still have those underlying phonological processing difficulties? Where would they sit? I'll hand over to Helen, but Helen, do hand over to others to contribute to that as well.
Thank you. I think to a large extent it depends on what the phonological difficulties are, and catalyze is very clear that if it's phonological awareness, then it's not DLD, even though obviously phonological awareness, I don't think we know enough about phonological awareness really in relation to speech and language. We know a lot about it in relation to literacy. And, I think there is an opportunity for DLD phonology, but we have to be really clear that it's perhaps underlying the language difficulties. And I'm not sure that we at the moment have appropriate diagnostic tools for us to be able to confidently say that.
Marit or Kakia, do you want to chip in there, anything to add to that?
Yes, I think that in this particular case of a child resolving in terms of output, but not resolving in terms of perception or processing, if I understand, then you have to look for something much more specific in the output. Okay, so if you use if you test a child and you test only on articulatory basis, you don't go deep into phonological basis, phonological characteristics of a child's speech, you might not see the actual problem being there, even if it has resolved. What does it mean? We resolve, okay, on the basis of what? So I also think that the underlying perception, processing, is a key factor in the prognosis. And I do think that if children struggle with their early expressive phonology at the beginning, and you don't target specific phonological goals through intervention, what you will end up is having a child without very robust phonological underlying representation. I'm using this term all the time because I do think that this is how you increase the representation, through particular and over production, not articulatory, but phonological. Okay, so to answer the question, I would check the child, I would challenge the child's phonological system through very specific words that tax homonymity. It's a Greek word. So use words that are phonologically dense, then you will see the child system in its really true merit, and also test perception processing.
Thank you, Kakia. That's really helpful. Marit, do you want to add anything to that point?
Well, I agree with Helen and Kakia. They already had some good responses, I think. Maybe I'll just pick up on what Helen also said about having the tools. And at least for Denmark, I know we have some challenges here. So we can definitely assess and see that the speech problems maybe have resolved the expressive part. But then assessing and tapping into what's underneath is really, really difficult right now. So I can definitely see the challenge in picking up on that, and also then where should we put them? Because right now maybe there's something that we actually cannot really see or assess in the children, but still have a feeling of that maybe something is going on. So at least for Danish, we need more clinical tools actually to be able to be looking into that.
Mm-hmm. Kakia, did you want to add something?
Yes, I don't know if what I'm going to say fits to our theme today, but a lot of children who might not resolve in terms of who might seem to resolve but have also perception problems. I think a speech language pathologist or the specialist should look into ruling out central auditory processing deficits that come along with this, which is a totally different area, but that should also play a role in to answer the our colleagues' question.
Thank you. That's great. Really full answers there. That's really helpful. So, and the second part of that question was more of clarification. So the questioner said, if the child also has problems in speech output, a combined DLD and SSD diagnosis would be appropriate. And Helen, I think that's where you were going, wasn't it? That this two co-occurring conditions is the way that we would describe it. So, yeah.
But I think if you've just got phonology and there's no other language difficulties, so you haven't got vocabulary difficulties or syntactic difficulties, then we shouldn't just be making a DLD diagnosis because there's phonology. I think that should be occurring with other language difficulties. And although it's very likely that there will be language difficulties, I think we need to be really, really careful, because we could end up sort of overburdening a child with diagnoses that are not really necessary. And then that creates alarm for parents and, you know, and often for the child themselves. So I think we do need to be really careful and perhaps revisit Catalyze. And I think more research will be coming out. It's early days, so there will be more research which comes out, which very specifically is looking at DLD categories and language and particularly the phonology, because we now have terminology for that. But I think we probably have to wait a year or two until that actually happens.
Great, thank you, Helen. This next question, I'm going to move on to another question now. And Marit, I think I'll hand this one over to you to start with, and then please do hand over to the others. So the question is about, we've got a couple of questions actually about persistent SSD. So this particular question is saying, should we have a separate label for persistent SSD? What about children who have typical error patterns that persist? Is there a point when that should or could be described as a disorder? I'm just mindful, Marit, of your comments about, you know, when problems persist beyond age 5 and how we need to sort of be careful of that. I wondered if you had any thoughts in response to that question.
That's a very good question. Yeah, we've actually been discussing this a little bit for the preparation for this panel. Now I'm working a lot with the classification model by Dodd, and there, we look at the typical patterns compared to the atypical patterns to decide the delay and the disorder. Also, I think if we look at the prognosis, we can see from research there that often children with a phonological delay will have a better prognosis regarding literacy, for example, compared to children with the consistent phonological disorder, when who often have some problems with phonological awareness. So I think this changing the category from being delayed to being suddenly having a disorder can be maybe problematic if we look at the prognosis and what we know, what we maybe can predict about the group of children. But I definitely can understand this question that if a child just keeps having this persisting typical speech errors, that maybe something else is going on. And that's where I then now said maybe we should also look at more general and maybe more is going on than just the phonology, because I think that's maybe often the case that we start with what we hear, and that's the phonology. We can hear that the phonological errors are there, even though they maybe are only typical, but we then don't tap into vocabulary, sentence, grammar, phonology, morphology, syntax, and language reception. So maybe we should then go back and to our assessment and look at what have I assessed already. Is there something I'm missing, to see whether there actually is a broader language disorder, maybe DLD going on, and not just only the phonological delay that we can hear. So maybe, not going from delay to phonological disorder, but maybe then see if there's a general maybe language disorder going on and not only just phonology. I don't know what Helen and Kakia are saying to this.
I was going to say, just ask you, Marit, because children in the UK, and I assume in the United States and in Australia, are still actually acquiring speech sounds when they start school at age 5 or 6. Whereas in Denmark, it's obviously very different, because children have all their speech sounds at such a very young age. And actually, I think you made a really important point, that unless we have developmental norms for a language, we don't know. And obviously, you didn't know that until you did that study. So there's a longer gap in Denmark between what you would expect children to. So I just wondered if, in a way, that's why you see more children presenting with speech sound disorder than language disorder, or whether actually fewer children have persistent speech difficulties when they are 5 or 6, because there's more time between that age, acquiring speech, and the age that they would be entering school, or even looking at a DLD diagnosis. So that in actual fact, I don't know whether this is the case, whether actually those children, they've got another 2 years on UK children, which they could get intervention in. I don't know what you think about that.
Well, that's true. That's of course if a difference if the typical children have finished now their phonological development at 3.5 years. And that's also there where I actually think that the children with DLD then maybe already show that they are different, because when they still have typical phonological patterns when they're entering school, and the other children have been finished for almost 3 years, that's a big delay. And there I think it's really a symptom of that more is going on than just the phonology. I know from a colleague who works in Copenhagen, that she also said that often we can see now the speech disorders, but they will then actually during the first year of school resolve, but then we have the grammar problems. So then the problems shift, like we also can see it in other languages. But we have, regarding more, I think you also asked if we have more children with phonological disorders. And actually a study I did show that we have, it seems like when we make a cross-language comparison there, that we have more children with consistent phonological disorders compared to just being delayed. And that's maybe because Danish is a little bit different in its phonological structures. It's some really recent interesting research also has shown that it's quite difficult to children to process this. But if they then have kind of gotten the clue of how to segment the words, they're really fast, and if they're typically developing, are finished already at 3.5 years. But if they're struggling and with phonology, then maybe more can go wrong actually from these children, and then we see more actually speech disorders and not just speech delays in children.
Yeah, that's true. I do think that we need to be very careful in how much the delay is a delay in terms of developmental period. How much time do we give children to vacillate or to move in the delay spectrum? A 5-year-old who is facing speech sound disorder, speech sound challenges, let that be in the form of typical or atypical phonological process, that child is not really moving forward, okay? So a 6-year-old who's back into Villers, for example, to take a very common phonological process, or to take an uncommon process, which in Cypriot Greek is very common, they need the initial consonant deletion, that is the deletion of the word initial onsets, okay? Then if we have a 5-year-old whose speech is loaded with these patterns, even if these are considered developmental patterns, then I don't think this child should be considered delayed. Children who don't really make a lot of progress fast enough, even after intervention, should be considered or should be put in a different category at risk for persistent language challenges in the form of grammar, in the form of narratives later in life, in the form more phonological also issues.
Thank you, Kakia, and thank you to the couple of people that asked that question about persistent speech disorder, and there is a growing literature, I think, for that field, and particularly talking about the nature of persistent speech disorder and its combination of differences in error patterns, but also differences in presentation of both phonological and motor elements, and that maybe that is
exactly. Children with typical but delayed phonological patterns with very poor progress skills are children usually that might fall in the spectrum of child apraxia of speech, okay? And that will need further clarification and, of course, the magic word of differential diagnosis. And there are words, there are stimuli that allow you to see this inconsistent pattern. So you should also think about that. You know,
that fits very well, Kakia, with another question, which I'm actually not going to suggest we address today. We had another question about clarifying the difference between articulation disorder and also CAS and also dysarthria. And the great thing is that is very much the focus of our next panel. So we will be discussing that further then. So if that's your question, then join us next time in December. Right, just a few more questions that I think would be good to just explore. And I think this really starts to think about how we use the taxonomy across different languages. And I'm going to hand it over to you guys to decide who you want to pick up on this. But the question is, how does a taxonomy with SSD as the umbrella term, and also broadly using the DOD terms, as you've discussed in the presentations, how could that work across different languages? What would be the same and what would be different? I don't know which one of you wants to pick up on that.
I think Marit's got some research that she's done in that area.
Great, go for it.
Yes. So just to, you asked where would it be different for other languages?
Yeah.
Well, my research has shown that when we're using SSD as an umbrella term and then look at broadly the DOT classification, the subgroups, the differential diagnosis, actually it's possible to apply the different subgroups to Danish, even though it's not English. But we saw a shift in the prevalence across groups. So we could see that we could find the same error patterns regarding articulation or phonological problems, the inconsistency, and also childhood apraxia of speech. But the prevalence was different for the different groups than compared to English-speaking children. But I think also, for example, now we talk about phonology today, but articulation is also a subgroup there. And there we also can see again that the speech sound system of the language, of course, is of importance. So I think in the English-speaking countries, you have both the rhotics and also the sibilants who typically are affected by articulation disorders. And in Denmark, actually, we only have the sibilants who typically are affected. So there would also be some characteristics, language system symptoms that you have to adapt in order to see what's the difficult thing here for the children in this group for this language. Yeah, so there we could see some differences, that children were having some different challenges because of the Danish system compared to the English speech sound system.
And do you think that's something that you would expect to see in other languages as well, that's not just unique to Danish? You would expect this variation? And how are there other areas where we might expect to see variation with other languages?
I think that classification system has been investigated in other languages as well, for example, German and Maltese, I think, and Turkish. And that also can be applied, they found. And actually, they also had, I think, more prevalence rates, which corresponds to that what was found for English-speaking children. So it looks quite promising to apply.
I agree
for the SSD term.
Yes, I agree with that. That taxonomy, that taxonomy is it's universal in a way. What's going to change is the age at which different pattern and parameter will apply as a function of each language. Okay, for example, the voicing system, we have a study where we see Standard Modern Greek and the Cypriot Greek dialect, and we see that children in Cypriot Greek do not achieve adult-like productions of the voicing system, the pre-voice, the voice, and the aspirated stops until they're 4. Whereas in Standard Modern Greek, because you have a 2 voicing system, they achieve that by the age of 2.5. So there you might see application of a taxonomy, but that shift in terms of age.
That's true. Yeah. So of course, then we go back to the norms. Also, it's really important to have normative data in order to be able to apply this classification.
Great, thank you. We're getting to the end. We've just got a few more minutes. We've had another question in that I'd like to share with you. It's an interesting one. Is it fair to say that in the DLD world, phonology refers to a cognitive creature, whereas in the SSD world, phonology refers to patterns observed in speech output? I think that's quite an interesting question. I don't know who wants to pick that up. I can reread it if you want me to.
Well, SSD is a broader term, right? And SSD as a broader term, if you go under the different categories, you would see that something cognitive processing is there. If cognition refers to the underlying representation, again, the UR. So SSD is something broader. And of course, you will see cognitive issues in phonology, but you would also see motor aspects. So you would see the cognitive language linguistic component, and you would also see the motor articulatory component. These are the 2 dichotomous, let's say, systems that support speech and language. Okay, so phonology is much more circumscribed, I would say. It's only one prong under the umbrella. This is my answer.
I think that what the person's getting at here is perhaps more about almost a cultural thing. That those people who are working more in the SSD world, when they use the word phonology, where they're talking about patterns, whereas when the people that are working in the DLD world, when they talk about phonology, they're talking about it as a cognitive linguistic. We might both acknowledge that it's a cognitive linguistic.
Exactly, it's the processing issue. Yeah.
Are there sort of cultural differences between those 2 communities, recognizing that both speech and phonology and language are interrelated fundamentally, but nevertheless we deal with them differently, and we have established research communities in the field of speech and research communities in the field of language, and we don't always interact that much. So I was just quite interested. I don't know if Helen or Marit, you want to add anything to this concept of perhaps they're considered slightly differently. The term means slightly different things in the 2 different communities.
Yeah, I think that's right. I think we've got a psycholinguistic model which spans both of those things, and which certainly from a speech point of view, we would investigate other aspects of phonology, not just the expressive aspect, but also in the sort of language disorder world. there is also the whole aspect of written language, and certainly working into schools, if you go in and talk about phonology, talking to a teacher, it's a really different thing that conjures up in their head around phonology and you know, phoneme awareness and all of those sorts of things that relate to literacy. So I think there is, to some extent, but also a big difference there. But also there is a lot of similarity as well, and maybe we need to be more precise in whether we're talking about productive phonology or phonological processing or phonological awareness, and actually have a more refined terminology or taxonomy in that area in order to make that a lot clearer, so that again we're talking the same language about phonology.
Yeah, it's a good point to end on, in a way, to come back to that terminology issue which is driving this whole panel series. Marit, just very briefly, is there anything that you wanted to add to that point before we finish?
Yeah, maybe I will just pick on what you said also, that researchers are not always working together and talking together. And I think that's actually also a good point, because if we want to support evidence-based practice, I think it's also important actually that we maybe have more research collaborations in the future between researchers who are looking at DLD and other researchers who are looking at SSD, and actually make some studies together in the future, because that's maybe also why it's a little bit confusing now with the overlap between these two areas, because we haven't had a lot of research actually who focused on the overlaps between these two areas. So that hopefully will come in the future in the next years.
Mm-hmm. Thank you, Marit, thank you. I think I have one last slide that is just going to be shown, which just shows you the dates of the future panel meetings. Our next one is on the 2nd of December. We will be sharing information about that, probably via Eventbrite. I think we probably can do that, but also via Twitter and via the IALP website. So do look out for that. That's going to be a very interesting panel presentation with Susan Ravachu of McGill University, Angela Morgan, Murdoch Children's Research Institute in Melbourne, and Edwin Mass from Temple University. So do join us for that. I would just like to end by thanking our speakers, Helen, Marit and Kakia, for joining us today. It's been absolutely fascinating discussion. I particularly just like to acknowledge, Marit and Kakia, that you have not been speaking in your first language, and I just am always in awe of people that can speak so well in a second language. But I just want to acknowledge that we really appreciate that and the extra burden that places on you. I think that's all. Thank you everyone for joining us.
Thank you for giving us this opportunity. Thank you very much.
Well, thank you to the rest of the Child Speech Committee. The recording will be available. The link will be on the IALP website, and it should be live, it should be available from immediately after we end today. Thank you all for joining us. Have a lovely weekend. Bye-bye.